So I think it's 7 o'clock. We should start the session.
Go ahead. Yes.
Okay. Good evening, everyone. I, Dr. Shreya Lal, Medical Advisor at MQ Pharmaceuticals, welcome all of you to this another interesting session of HIV updates. Today's session is focused on the 41st HIV Long-Term Survivors Awareness Day. Mr. Taze Anderson founded HIV Long-Term Survivors Awareness Day on June 15, 2014 to honor long-term survivors of HIV and raise awareness of their needs, health issues, and journeys. The selection of the June 5th date for this annual observance coincides with the anniversary of the first official reporting of what became known as the AIDS epidemic. I would now take this opportunity to introduce you all the panel of speakers for today's webinar. We have with us Dr. Atul Kakar sir, Dr. Vasant Nagvekar sir, and Dr. Falguni Parikh ma'am. Now let me introduce each speaker. Dr. Atul Kakar sir is Professor, Senior Consultant and Vice Chairman at Department of Internal Medicine, Gangaram Institute for Postgraduate Medical Education and Research, New Delhi. Sir is a Fellow of Royal College of Physicians of Glasgow, Fellow of Indian College of Physicians, Indian Association of Clinical Medicine. Sir is an examiner at Royal College of Physicians for FRCS. Sir's area of interest are rheumatology and HIV medicine. Sir has more than 120 publications in international and national journals, 2 textbooks, and 16 books for lay people under his credit. Sir is primary investigator for many clinical phase 2 and 3 drug trials on amyloidosis, osteoporosis, and rheumatoid arthritis. Sir is the recipient of Srimati Pawan Kumari Jain Oration Award, Delhi chapter, and Dr. K.C. Mahajan Best Academician Award. We also have with us Dr. Vasant Nagvekar sir. Sir is attached to Leelavati and HN Reliance Hospital, Mumbai. Sir has postdoctoral fellowship in infectious disease from Tamil Nadu, Dr. MGR Medical University. Sir is an infectious disease and DNB medicine teacher at Leelavati Hospital and Research Center, Mumbai. We also have with us Dr. Falguni Parikh ma'am, who is consultant, internal medicine and infectious disease at Kokilaben Dhiru Ambani Hospital. Ma'am has special interest in HIV, tuberculosis, tropical infections, and prolonged pyrexia. Ma'am runs an adult immunization clinic at KDH. Ma'am was attached previously to TN Medical College and BYL Nair Charitable Hospital at Mumbai. Ma'am is an executive life member of Clinical Infectious Disease Society of India. Ma'am is also Fellow of Infectious Disease Society of America and has more than 125 publications in various journals. Ma'am has also been on the editorial board of JAPI, an API textbook of medicine. Ma'am is also the recipient of M.J. Shah Memorial Award in Tropical Medicine from API in 2003. The webinar will have sessions from all the 3 eminent speakers, following which we would have a question and answer session in which all the attendees can ask their questions or discuss any case which they have encountered in their clinical practice, which requires special mention. Now, I would request Dr. Atul Kakar sir to start with today's session. Sir?
Thank you so much.
Yes, sir.
Yeah, thank you so much. Okay, welcome to this HIV update where I'm going to cover the initial contact with HIV/AIDS patient. And majority of the people get perplexed when they see a report of HIV. They don't know what to do next and whom to send, whether to treat themselves, what tests to be done. So this gives you an overview in the next 10-15 minutes. It's just going to give an overview of what we do and how do we normally follow these kind of a patients. So these are based upon the National Guidelines for HIV Care and Treatment 2021. This is a document which has been given by NACO. Also, there is some additional information which has been taken by WHO in certain papers, which I'm going to cover during the course. Once we have a report of HIV, we should see firmly whether the diagnosis is confirmed or not, or whether it's a false positive report. A false positive report can be seen in many autoimmune diseases, also in alcoholic hepatitis, primary biliary cirrhosis, leprosy. If the patient has had multiple pregnancies and due to technical error, which is one of the commonest reasons for this. Also, when you have a report, you should also see if the patient has been tested in the past, what was the date and time, what was the indication, and what was the reason for the getting the test done, and what was the date of the last negative HIV test results. These things are very important, and as we go into seminar, you will realize the importance of these things. Now, the importance of the clinical assessment for such kind of patient is to identify what is the current HIV-related illness that may require treatment. Also, to determine the need of opportunistic infection prophylaxis, determine the nutritional status of the patient, also to know about what is the present and the past illness, especially related to the TB and the sexually transmitted diseases, and also to assess the need of psychosocial support for the patient. So whenever the patient comes, we need to see what stage of the disease is. Are we catching the patient into the acute phase where the symptoms are like, typically a flu-like symptoms, or if the patient is symptomatic, which is stage 2 or 3, or patient has got advanced AIDS, which are multiple diseases which can be, causing this kind of a thing. So it's important to know exactly, because that also will help you to know about the various, treatment to be given to this kind of a patient. The treatment algorithm will also depend upon what are the comorbid problems, and it's important to record the status of diabetes, hypertension, cardiovascular disease, ongoing hepatitis, renal diseases, the neurological diseases, especially the seizures or if there's any stroke, because that may influence the choice of the antiretroviral therapy also. So among the history, it's important to know the history of past or present use of drugs, and also if there's any history of unprotected sex or any sexually transmitted diseases or use of any blood or blood related products. Substance abuse is also very important to know whether the patient is taking tobacco, alcohol, any other drugs. So these also need to be recorded in detail. The risk factors other than this, whether the patient has got history of, sex with the male sex worker or a female sex worker, because these are also very important. If there is any history of any tattooing, ear piercing or body piercing, which are getting very common these days now. Also, the risk of perinatal transmission and all the serodiscordance couples should be recorded at this moment. So now when we have a clinical review of symptoms, you should also record about weight loss, any lymph nodes which are there, night sweats, headache, change in the appetite, skin, or any sore in the mouth or painful swallowing the patient is having, any chest discomfort or the cough, abdominal symptoms, or any tingling or numbness in the hand or feet, or any muscular weakness, and also vision problems which the patient may be suffering from. From the past history, what we require is surgical history from if the patient has got any history of any complicated or uncomplicated surgical intervention. the medical history, which may include over-the-counter drugs which are available, the pain medication or herbal supplements which the patient is taking. What is the psychological and the social support, including the financial status of the patient? If the patient is currently married, how many partners the patient has, and if the patient is planning any family extension, and what are the family members in his family currently. So this is also very important, and travel history is especially important because it may give you clue of some opportunistic infections. So things which are not to be missed are oral candidiasis, persistent diarrhea, tuberculosis, herpes, oral hairy leukoplakia, PCP, pneumonias, meningitis, toxoplasmosis, or Kaposi sarcoma, or MAC, or CMV infection, and even invasive cervical cancers. So from the history pertaining to chest, the common presentations which are important for our patients are tuberculosis, community-acquired pneumonia, and PCP. The latest chest X-ray should be recorded, and also there should be, in case there's a past history of tuberculosis, it should be mentioned what were the drugs and what is the duration, and also history of exposure to the other family members of the contact. And at this juncture, the TB screening questions, which are the 4S, the screening questions, which is any cough, weight loss, night sweats, should also be recorded at this junction. One should remember that in India, it is the third highest burden of HIV, related countries in the world, and second among the world which have got tuberculosis as a co-infection. And these are the various states where the tuberculosis plus the HIV can coexist. We should also remember tuberculosis is a notifiable disease, and there's alarming increased level of drug-resistant tuberculosis in HIV state. These sexually transmitted diseases should ask for genital ulcers or any other lesions which are there. And in female, the abnormal vaginal discharge and lower abdominal pain, which may be also present. This is a very interesting study which shows you the prevalence of STDs in HIV patients and the condom use among male to female transgenders. It's a retrospective analysis from the Chennai hospital, which showed that the incidence of STI is close to almost 49% as compared to the general population, which is almost 5.4%. And syphilis was the commonest STD, followed by HIV and genital warts, and then gonorrhea among the various STIs. The physical examination, I think we all know about it, and the body weight, the temperature, blood pressure, because this is all very important because we need to pick up certain severe heart signs which we are not missing, and I'm going to cover that. If you have those signs at the initial workup, it means that the patient has got very severe infection and they need to be treated in the hospital setting. Also look for any track marks or the soft tissue infections, which may be very common in patients who are using intravenous drugs also. Now, the weight loss history is very important in this. If there is a rapid weight loss, it gives you an idea about, the patient may be having an active OI, especially if it's associated with fever. However, if the weight loss is gradual, it may be related to malnutrition or various other illness. The skin problems, there are multiple skin problems which may occur in HIV, and there are books, dedicated to this topic. And it's just not possible to cover this, but one should be, at least know the common the skin infections, which are very important, which include seborrheic dermatitis, herpes simplex, and zoster, which may be a multi-dermatomal infection. And the lymph node enlargement may also be seen from posterior cervical lymph nodes to a condition which is called persistent glandular lymphadenopathy, which is usually multiple bilateral soft, non-tender mobile cervical nodes, which are seen other than in the axilla or in the inguinal region. But one should remember the tuberculosis is one of the commonest presentation to have, especially if the patient is having constitutional symptoms. In the mouth, various manifestations have already been mentioned, so it should not be missed. Also, you should remember difficulty in swallowing is usually not always due to esophageal candidiasis and maybe also due to the esophageal cancers, which should be also looked into at this junction. So these patients definitely require a psychological evaluation, and there may be anxiety, which may be mild to moderate after seeing the report. And at all junctions, anxiety, major depression, and various other, psychological manifestations may be seen. So one should be aware of these, whether it is from the initial contact to throughout the course. These may be there, and we need to address these also for the patients. So the nutritional requirement is a very important topic, which also has been mentioned by NACO, that it should be assessed. And poor nutrition, it leads to HIV weakening, and also it can lead to frequent illness, lead to impaired body tissue, and also lead to weight loss further. And as we know that majority of the patients who have got HIV associated infection, there's increased need of the proteins, energy, and there is also a deficit of micronutrients, which are usually seen in the form of iron, zinc, and vitamin C, which has been mentioned. Especially if you have opportunistic infection, there is accelerated need for these kind of nutritional supplements, which need to be also put on the prescription for these kind of patients. Now, the causes of undernutrition in patients with HIV or AIDS, especially when we're talking about, patients who are doing, taking medicines for long. It could be lots. It could, vary from reduced food intake to inability to eat because of painful lesions due to some infection or something else which is happening. The loss of appetite may be due to HIV infection per se. It could also be due to, depression or change in the mental status. Also, the poverty can lead to this kind of the food excess, which is access to the food is not there, especially to the protein, or which is the main source which is required for muscle building for these kind of patients also. Also, they may be physically handicapped because of some visual problems or the neurological problems which are there. Opportunistic infection, in fact, can add to all this kind of a thing. And also the antiretroviral therapy itself can be associated with this kind of thing. And it's been said that BMI less than 18.5 is a very strong independent indicator for mortality and morbidity for HIV positive individuals. And this is the normal classification which, for BMI, which normally we follow. So counseling, education, information, and sharing, information sharing is very important. And also should remember, almost 20 to 30% of the energy should be also be provided by fat. We're talking about proteins, but fat also is very important. And protein requirement 1 gram per kg per day, which may increase when you have severe illness or an opportunistic infection which may be present. So these are the 4-5 baseline tests which are done. you have confirmed diagnosis of HIV. This is by the WHO strategy 2, which is available. And I'm not going into detail. You can cover in the question answer session. We also do CD4 cell count with percentage. We do a plasma HIV RNA, which is also called viral load testing. And in case you have resources, we should also do HIV drug resistance testing in all patients at the start of the treatment, pregnancy test, especially if it's indicated, and G6PD in case you are planning to put the patient on prophylaxis with sulfur drugs also. So now these are the visits, which are planned according to the National AIDS program, which we have. So the day 1 visit, we should ask for the 4 symptoms of tuberculosis screening. You should do a proper physical examination, assess the behavior, psychological and social assessment, see the educational level of the patient, the employment history, the financial resources of the patient, the social support, how many family members are there, and also know about the discordant status and readiness to disclose to the partner. Also try to understand about what is the patient's understanding about the subject related to transmission, and also if he is willing to reduce the reduction and take the treatment. So these are very important to assess on the visit 1. The visit 1 also should include the nutritional assessment. We should recommend the condom usage throughout, and get those tests done which have already been mentioned, and start the initiation for opportunistic infection prophylaxis. So in addition, we also would require a few more tests, which include the CBC, sugars, creatinine, lipids, X-ray, and testing for hepatitis B and C at this junction, including the VDRL, which has been recommended at visit 1. Now, the NACO also tells us that leishmaniasis is very common in the certain states, and we should also do RK39 strip test to rule out associated leishmaniasis, especially if the patient is hailing from Bihar, Eastern UP, Jharkhand, or West Bengal. And this paper talks about changing trend on epidemiology and clinical presentation and diagnosis of leishmaniasis, especially in presence of HIV infection, and how the infection is now not limited to this 4 state and may be seen in various other conditions also. What we also do, and it's recommended to do an anal or cervical pap smear, and this is a paper published from our center where we have mentioned about in homosexual contacts, we do the anal pap smear to know about the prevalence of anal cancer in homosexual patients. So additional tests, in case the patient has got chest symptoms, you should do CBNet, and but it should also depend upon, in case this test is not available, we should not withhold the treatment, start the treatment in case it's clinically indicated. Now, the second visit for such patients is usually indicated between 3rd to 15 days. Again, you go through the history, clinical symptoms, the symptoms of tuberculosis, see the prophylaxis, provide psychological and social support, see for, whether the patient is prepared, because at this moment, in fact, now it is believed that you should start the treatment as soon as possible, and I'm going to come that also. So the treatment should be started within 7 days from when the diagnosis is made. So this may be the time when you've already started treatment, although many centers, they start on day 1 itself. And the third visit is after initiation of ART. Again, you're going to review all these kind of things which have been mentioned. There's nothing special about it. And just seeing if the patient is going to continue all this or not. So this is a very interesting study which talks about how well are we prepared for the initial assessment of HIV. The study is not from India, it's from the Spain. And they looked at almost 13,000 plus patients where in majority of the patients, the CD4 cell count and the viral load was done. However, the serology, which is the standard of care for hepatitis B, A, and C there, plus syphilis, was not done in all patients. Also, the standard of care, they required total cholesterol and creatinine, which was again done in almost close to about 75% of the patients or so. So it means that wherever we are, this is perhaps we are not following the, the set standard of care algorithm for following this treatment and also, the way these patients should be followed. Now, when we were talking about serious illness and the various vital signs, we should remember any temperature which is more than 39 degrees with headache, or respiratory rate which is beyond 30, or heart rate more than 120, or oxygen saturation which is less than 90, or there is an altered mentation, or any neurological problems, or if the patient is unable to walk unaided. This requires an emergency treatment and hospitalization in the nearby center. So finally, to conclude, the assessment of the stage of HIV is very important, and it also helps to determine the risk for other opportunistic infections and also identify what is the comorbid conditions. The initial assessment is very important also to establish a patient doctor relationship, because it's going to go in a long way, especially in the private setup, because once the patient is there, he's going to follow for long. It's important to educate the patient about the natural history and the management and the drugs which are available. And in each consultation, the patient should be screened for tuberculosis and various other opportunistic infection. If it's coming from history, it's okay. Otherwise, necessary tests needs to be done as suggested by a national program. And this is the book which we've written. This is HIV/AIDS Test and Treat. It's available also online. Thank you so much.
Thank you, sir. That was a really interesting session on how to go about the initial workup of an HIV patient. Now I would request Dr. Vasant sir to start his session. Good evening, sir.
Good evening. Hi, Shreya. Hi,
Good evening, sir.
And hi, Falguni.
Vivek, if you could make sir the co-host.
Yes, sir.
Hello, Dr. Shreya, can you see my screen now?
Yes, sir. Yes, sir. Your screen is visible.
Okay, thanks, MQ and Shreya, for giving me this opportunity. And I think I'll be talking about the newer ARTs, what are the pros and cons about the new ARTs which are there in the pipeline. In fact, our life has been made very easy with the newer ARTs, with some minor pros and cons of each of these molecules. And let's look at these various molecules compared, and we will also discuss about the various earlier molecules and what has been the comparison between the older molecules and the newer molecules. So these are the various drugs which were there in the pipeline, and I think among the NRTI which we commonly use in our clinical practice is the tenofovir and now the TAF, abacavir, lamivudine, emtricitabine, and zidovudine. I think I have been using stavudine earlier in my practice, but I'm out of this. NRTIs, I've used only the efavirenz and nevirapine, and I've not used fusion inhibitors. The PIs, yes, lopinavir, atazanavir, ritonavir, and darunavir have been there in the market and still available. Merovera was there during my time, but I have not had the opportunity to use it. And of course, widely using the integrase inhibitors, that is the dolutegravir, bictegravir, and raltegravir. All of them having some minor differences, advantages, and disadvantages. And let's look at all this. In the NRTI regimens, we clearly seen there are 10% resistance which occurs, and within the countries to follow from 2017, you will see the number of countries which are following about the integrase inhibitors. So I think the present era is all about integrase inhibitors, and we are moving away from the NNRTS, that is nevirapine and efavirenz, towards the integrase inhibitors. Efavirenz still it is still being widely used even in the present era. But I think we are moving, actually, we are moving away from the NNRTA to the integrase inhibitors. So the WHO and more or less the DHHS is a similar guidelines, where the first line of treatment now they say it is tenofovir with either emtricitabine or lamivudine with dolutegravir. That is the first line treatment. Alternative is to use efavirenz, but the newer regimen says that you use, instead of 600 milligram, we use 400 milligram of efavirenz along with the tenofovir and lamivudine. In children, it is abacavir, lamivudine, and dolutegravir. But very important to know that whenever you're using abacavir, you have to get a HLA B5701. Otherwise, if it is positive, you may land up in a hypersensitive reaction. So if you see that WHO, which was earlier always efavirenz or nevirapine based regimen, has moved away towards a dolutegravir based regimen. What is the reason for that? We will see in our subsequent slides. So this is the second line. If you see again, is again dolutegravir based regimen, and also alternative second line treatment would be a PI based regimen, which your atazanavir or possibly darunavir, ritonavir scores better, because I think very important to know that the pill burden has to be as Dr. Kakar said, it has to be as minimum as possible. So preferably one pill per day is what is preferred, because it is not a 1 month or 1 year's treatment. It is a lifelong treatment, and the most first thumb rule of the success of a antiretroviral therapy is that the patient should be able to adhere to the treatment whatever you is given lifelong, and that is only possible when you give minimum pills. Even when you give twice a day pills, it is a problem. You have to people skip one dose, so one pill per day, and that is possible with efavirenz based regimen, dolutegravir based regimen, or dolutegravir or atazanavir based regimen. That is possible. So that is dolutegravir. We don't have a combined pill available as such, but once a day is what is possible. Again, I think the similar second, third line regimens are predominantly, it will be a PI based regimen, or it would be a integrase inhibitor based regimen. So even the resistance testing, we used to do a lot of genotypic resistance testing. I think we are far more ahead from that. Even genotypic, we do to test ourselves whether we are on the right track about the genotypic resistance testing. But the main thing is that with this integrase inhibitor regimen, you will see the various studies which I'm talking about, and you'll see that is the genotypic resistance really required. But yes, to have the epidemiological what is happening to the pattern of resistance, we do genotypic resistance, but actually practically it may not affect. So now let's come to the why are we moved from efavirenz based regimen to the integrase inhibitor regimen. This is the first study which I'll be talking about. Is a single study which compares dolutegravir plus abacavir lamivudine versus the efavirenz tenofovir emtricitabine based regimen. And though in India we do not prefer to use abacavir as a first-line treatment, we always use dolutegravir, either tenofovir lamivudine, or we use dolutegravir with TAF with emtricitabine. That is the regimen as a first line we use, or it is the efavirenz based regimen as well. So abacavir, again, whenever you're using, it's very important that you do an HLA-B5701 blood test, which if negative, only then you can continue to, only then you can use an abacavir. And also one important thing was, when efavirenz based regimens were there, whenever your viral load was more than 1 lakh, the failure would be slightly more with the abacavir based regimen. But I think with dolutegravir based regimen with lamivudine, that it really does not matter what is the viral load in that. But when it was an efavirenz or nevirapine based regimen, we used to prefer avoiding abacavir when the viral loads were more than 1 lakh. So let's come to this single study which compares your old drug efavirenz versus the dolutegravir based regimen. What does the study show? This single study showed that the success of at 48 weeks with dolutegravir based regimen was 88%, whereas with the efavirenz based regimen was 81%, and it proved superior virologic efficacy. With also, if you see the CD4 count, there was almost increase in the number of CD4 cells by 60 to 70 in the dolutegravir based regimen compared to the efavirenz based regimen. So not only there was a virologic efficacy, superior efficacy, but also the immunologically, also patients were fared much better at 48 weeks in the dolutegravir based regimen. If you see the adverse effects were like, it was reported rates of neuropsychiatry were much less in the dolutegravir based regimen compared to the efavirenz based regimen. So I think all your adverse effects, if you see the depression or if you see the headache, all those were slightly more in the efavirenz based regimen and dolutegravir based regimen than the dolutegravir. Also, the discontinuation was slightly more in the efavirenz based regimen. That was because of the adverse effects which efavirenz based regimen, many of the patients are not able to tolerate efavirenz based regimen, though you have to counsel them very well for that. You will have that giddiness and insomnia and all that for 2 to 3 weeks, but the discontinuation was slightly more in the efavirenz compared to the dolutegravir. So the single study key points to compare your newer dolutegravir based regimen versus the older efavirenz based regimen was superior virologic and immunologic efficacy of dolutegravir plus abacavir lamivudine versus the efavirenz based regimen, lower rates of discontinuation, as I said, the decreased neuropsychiatric and rash events, and also resistance profile favored virology failure favored the dolutegravir base. Now, another important landmark is that we have moved away from, if you see, when I showed you my first slide, we have moved away from efavirenz 600 to now 400. And is there any good evidence to say that 400 will do as good as your 600? And so why no efavirenz 600 milligram in future? These are so many reasons given. I will not go into this, but this was the ENCORE study, ENCORE 1 study, which compared efavirenz 400 versus 600 milligram of efavirenz head-to-head trial, along with both the groups had tenofovir and emtricitabine as a common drug. So two NRTIs, tenofovir and emtricitabine, and they had efavirenz 400 and 600, and we had results at 48 weeks and 96 weeks. And what we found was there was no difference in the clinical outcome, whether it was virological or immunological, between the 400 and 600. In fact, the adverse events in the 400 group, if you see the one which is squared, was much less in the patients with adverse event related to efavirenz were 39% compared to 48% in the 600, whereas stopping were in 13% of the 400 group compared to 23%. So definitely the clinical efficacy was all same in the 400 as well as 600. Rather, 400 scored better in that the adverse effects were less and patients to stop the treatment because of efavirenz were also much lesser than the 600. So this strongly proves that actually you don't require 600 milligram of efavirenz. 400 of efavirenz is as good. So now we have moved from, if at all it has to be used TLE 600, it has to be TLE 400. So that's another landmark. Now, another third paper, which now, so first we spoke about dolutegravir versus efavirenz. Second is we spoke about 400 and 600 efavirenz. Now, coming to the two integrase inhibitors, that is bictegravir versus your dolutegravir. So, what was the difference when bictegravir, emtricitabine, TAF was used against dolutegravir, emtricitabine, and TAF? Was there any difference in the clinical outcome, adverse effects, and all that? So this was a phase 3 non-inferiority trial. And if you see in this chart, I'll not go into details, but I would say that bictegravir and dolutegravir, so they formed non-inferior to each other, and both had similar adverse events and similar clinical outcomes. So that means bictegravir is as good as your dolutegravir, or dolutegravir is as good as your bictegravir. So there's not much of difference in that, in the clinical outcome of those patients. So next comes is the area study. So we have compared with efavirenz, we have compared with the two integrase inhibitors. Now let us compare dolutegravir, that is the talk down of antiretroviral therapy. Why are we discussing with dolutegravir? Because that is the regimen which DHHS, WHO, everybody is recommending. So we are just comparing to see is dolutegravir still best with the older one. Now this was a study which was conducted between dolutegravir, abacavir, and lamivudine versus atazanavir, ritonavir, tenofovir, emtricitabine, and what were the results of the area study at 48 weeks? And we found that the dolutegravir regimen fared almost in every group, whether it's a virological or whether it's immunological, it fared much better compared to your atazanavir, ritonavir. So treatment success with dolutegravir, abacavir, lamivudine was much better than atazanavir, tenofovir, emtricitabine, and similar adverse events were observed in both the groups. In fact, in the dolutegravir group, only 10 participants discontinued, whereas in atazanavir, it was 18 participants which were discontinued. Also, to know that atazanavir is associated with some renal stones and indirect hyperbilirubinemia, which is not really a concern. But clinically, virologically, the immunological virology definitely fared. Dolutegravir fared better in compared to the atazanavir, ritonavir. So we have compared dolutegravir with efavirenz, which says that it is better. We have seen that bictegravir, dolutegravir better. And now we compared with atazanavir, ritonavir, that is a PI-based regimen, and if we found out dolutegravir still has been a better drug. The next is the trial, which is the Flamingo study, which compares dolutegravir versus darunavir, ritonavir and this is plus the two NRTAs, and it's a 48 weeks data, which again shows that it is marginally, dolutegravir is slightly superior to darunavir at 48 weeks. But I have reservations about this because darunavir, ritonavir is equally strong, I would say, efficacy-wise to dolutegravir. Yeah, maybe some discontinuation with darunavir must have happened because it's a sulfa type group, and some skin rashes and adverse events were slightly marginally more with the darunavir group compared to dolutegravir. But this Flamingo study showed that dolutegravir had marginal benefit over the darunavir, ritonavir group, and I think that's about the Flamingo study. Now comes the so we have discussed and we have seen that dolutegravir in almost everywhere, 2 PIs and 1 NNRTL, we've seen that it is superior. Now let's talk about only dolutegravir and what happens with dolutegravir, whether we can use 3 drugs is it required, or whether we require 2 drugs, and what are the adverse effects of using dolutegravir with TDF, or what is the advantage of using dolutegravir with TAF in your clinical practice. So this was the Gemini 1 and Gemini 2 study, which was durable efficacy of dolutegravir plus lamivudine in antiretroviral naive patients with HIV infection. And this was 96 weeks results from Gemini 1 and Gemini 2. And in one group, it was dolutegravir with lamivudine, and the dolutegravir lamivudine continued, whereas the other arm was with tenofovir and emtricitabine. And if you see that more or less, whether you use a 2-drug or a 3-drug regimen, the clinical efficacy, the virological suppression was more or less similar in both the groups. And in fact, if you see, it was meaning both the groups had equal results in as far as the virological suppression, and that means your 2 drugs is equivalent to your 3 drugs. But what is the advantage of two drugs? When you use two drugs, it maintains non-inferior efficacy versus the three-drug dolutegravir regimen, that is dolutegravir, tenofovir, and emtricitabine at week 144. Overall safety and tolerability were comparable between the groups. There was a slight lower risk of drug-related adverse events with the dolutegravir emtricitabine because TDF was not done, so tenofovir was not there. So your osteoporosis, renal issues were much lesser in the dolutegravir lamivudine group compared to the tenofovir emtricitabine group. Changes, that's what, the renal and biomarkers. And these results confirm the durable efficacy, tolerability, and a high barrier of resistance to dolutegravir plus lamivudine, further supporting that two-drug regimen, dolutegravir and lamivudine, as a first-line treatment option for people living with HIV and AIDS. So this was the two drug versus the three drugs. And though I have not clinically used in my practice two drugs, but I think the way forward is some people who are not been able to tolerate TDF, or those people are putting a lot of weight with TAF or having renal issues, I think we can drop tenofovir and go with two drug regimen. Now, this was a Tango study. Now, the next come is the Tango study, which is almost similar to the Gemini 1 and Gemini 2. And in this study, the study was efficacy and safety of switching to dolutegravir lamivudine fixed two-drug regimen versus continuing TAF-based 3 or 4. So in this study, initially it was all 3-drug regimens, and then at 48 weeks, what they did was they switched from 3-drug to 2 drugs. That was the study which was carried out from 2 drugs to 3 drugs, and what happened to those people when they switched from 3 drugs to 2 drugs. I think Gemini 1 and Gemini 2 almost, it had been very clear that even at week 144, the results of 2 drugs were equivalent to 3 drugs. And I think we are expecting a similar results in this 2 drugs versus 3 drugs with lesser side effects with the 2 drugs. And the Tango study is also almost similar to Gemini study. And the conclusion of Tango study was that it was the largest trial to evaluate switching patients who are virologically suppressed on 3 drugs versus two drugs versus continuing the 3 drugs. So what happens if you just continue the 3 drugs, and what happens if you just switch from 3 drugs to 2 drugs? This was the Tango study. And this showed that switching to 2 drugs was non-inferior to remaining to a 3-drug regimen. And in fact, this finding supported that 2-drug is a switch option for people who have adverse events because of the TAF or TDF, which causes osteoporosis, weight gain, or renal toxicity. So that way. So I think on this basis of the results of Gemini 1, Gemini 2 Tango studies, the 2-drug regimen of dolutegravir with lamivudine fixed drugs combination now a recommended preferred regimen in the US, and it's also in the AIDS Clinical Society guidelines for naive patients as well as virologically suppressed with people who are living with AIDS. So this study shows that yes, you can switch from 3 drugs to 2 drugs if required, if you are having any adverse effects of one of the drugs which during your clinical treatment. What about dolutegravir and pregnancy? This was the issue, and I think even this has very made clear that dolutegravir, though it was supposed to be slightly teratogenic, but over a period of time we have seen that the teratogenicity is not so much. As far as possible, if you want to start it in the second trimester. But if some patient is already on dolutegravir, you can continue the treatment. The next, so we have made very clear that dolutegravir, that is integrase, are inhibitors, the way to go forward in various trials. Now let's look at about whether should we use TAF or should we use TDF in our clinical practice. Is there a need to switch or require that? So this was a paper which came in CID, weight gain following initiation of antiretroviral therapy risk factors, and they found out TAF and integrase inhibitors, that especially bictegravir or dolutegravir had an increase in weight gain compared to the TDF. And the risk factors were those people who had CD4 less than 200, or who had HIV viral loads more than 1 lakh, or black in normal weight, females especially black, and those who were an NRTA based regimen, they had a major reason for putting on weight. Okay, so the next study is that we'll discuss about whether dolutegravir plus 2 different prodrugs of tenofovir. That means we will use a study where this was a study which was basically studied between dolutegravir with TAF or dolutegravir with TDF versus efavirenz with TDF. So what happens in these three groups? Let's study this. So basically, this was a study which was carried. This was a study which was carried out to study these three groups. And in this, the background was integrase inhibitors, including dolutegravir, have replaced the NNRTS, and TAF is an alternative to TDF in high-income country guidelines. Tenofovir and TAF offer toxicity and cost benefits. Tenofovir offers resistant benefits in the era of rising NNRTI resistance. South African background NNRTI resistance estimated at 5 to 15%. In the beginning, he said it is around 10%. And this was the advanced study which was done where we had 1,000 plus participants. First group was dolutegravir, emtricitabine with TAF. The other group was dolutegravir, emtricitabine with tenofovir. And the third group was efavirenz, emtricitabine with tenofovir. So I think this is a proper trial to evaluate which group will do better and what are the plus and minuses of each of these groups. I think this is the best advanced study which will really tell you how would you go in your practice. I think all the three regimens are good, but let's see what happens. If you see the baseline characteristics of all the three groups were more or less same, and what we found out that the efavirenz based regimen, the virological suppression was marginally less. I'm still saying that efavirenz, I still have a lot of patients in my clinical practice who are on efavirenz based regimen doing extremely well. There was a marginal gain of the people who are in the dolutegravir TAF versus dolutegravir TDF compared to efavirenz tenofovir based regimen. Marginal difference. But what was observed was the renal adverse events, if you see, were comparatively lesser in the TAF plus dolutegravir. But when you have dolutegravir with tenofovir, your renal adverse effects are slightly more, both because of dolutegravir as well as tenofovir. And so here also, if you see efavirenz based regimen, the predominant drug is the TDF, which has a slight adverse effect, which was seen in 4% of the people. So I think when you have dolutegravir with tenofovir, you have to be slightly careful in monitoring the renal parameters compared to when your patient is on efavirenz based regimen or your patient is on dolutegravir TAF based regimen. So that is what this study showed. And also it showed that if you switch, suppose if you have a patient who is on tenofovir, dolutegravir and lamivudine, and if you switch him to dolutegravir TAF plus emtricitabine, you will see that those people after switching, their GFR increased by 1.5 ml per minute. If the baseline GFR was 60 to 89 ml per minute, and it increased to 4.1 if your GFR was less than 60, and those people who were continued on tenofovir had a decrease by 5.8 ml per minute. So definitely it showed that if you switch from TDF and if your creatinine is say 1 up to 1.3, 1.4, possibly switching from TDF to TAF would definitely improve your GFR. Next is what about the bone densitometry? If you see that again in those people who were on tenofovir based regimen, whether it was efavirenz tenofovir or whether it's dolutegravir tenofovir, your osteopenia was much more in both these groups compared to people who had TAF with dolutegravir. That means TAF with TAF compared to TDF, your osteoporosis is much less, as well as the nephrotoxicity is also less. So these are the advantages. Now, what's the disadvantages of TAF over TDF? And does it really have major adverse effects? So this, again, these were the three arms, and you will see that in men, in those people who are on efavirenz based regimen, they had put on 1 kg, whereas in women it was 4, and in the TAF group it was 5. In women, it was efavirenz was 3 kgs, and at 96 weeks, whereas in TAF, TDF plus dolutegravir is 5 kg, but TAF with dolutegravir had a massive weight gain of almost 10 kgs, or it was more than that. And also the body composition, if you see the trunk, limb flat, and redistribution was much more. And again, those people who were on TAF plus dolutegravir had had almost metabolic syndrome at week 96 in 8.4% of people in the males, whereas it was around 11% in the females. So some advantages do not come without disadvantages. So the TAF dolutegravir, the disadvantage is it causes massive weight gain, almost 10 to 15 kgs sometimes, or 10 to 15%, and it may cause diabetes, dyslipidemia, and a metabolic syndrome. So weight gain of 10% or more occurred in 1% of women and 42% of men receiving the dolutegravir TAF emtricitabine, compared to 32% of women and 27% of men receiving the dolutegravir tenofovir based regimen. In comparison, efavirenz was the best because it did not really put on, it did make a increase in the weight gain, because all patients of HIV will definitely put on weight gain. But this study very clearly showed that meaning efavirenz also puts on weight, but that is from his nutritional aspect. But dolutegravir with TAF has a much more weight gain in women more than men, as well as similar was observed even in dolutegravir tenofovir, but TAF with dolutegravir was much more. Again, the metabolic syndrome, if you see, was observed in 9% of dolutegravir TAF-based regimen, compared to 5% in the dolutegravir tenofovir and 3% in the efavirenz tenofovir-based regimen. So again, it is 3 times when you use dolutegravir TAF, your metabolic syndrome is 3 times more than what you would get in efavirenz-based regimen, and almost double when you use a tenofovir with dolutegravir compared to that regimen. So there are some advantages, but it does not come out without disadvantage. You may have metabolic syndrome, dyslipidemia, diabetes, obesity, obstructive sleep apnea syndrome. So all those will be much more in the dolutegravir with TAF-based regimen. And when people from efavirenz, from dolutegravir way, when they're given a choice to switch to efavirenz-based regimen because of the weight gain or metabolic syndrome, most participants refuse point blank to switch from the dolutegravir. They don't want to go back to efavirenz-based regimen because of the previous adverse effect what they had, which they had experienced in that in the previous when they took the ART efavirenz-based. So weight gain theories are return to health phenomena induced by integrity inhibitors. So weight loss with efavirenz, or maintaining the weight, is because of the TDF, which is inhibited. Also increase appetite, calorie intake, reduce physical activity. So multifactorial, which is known to be associated with weight gain. So in conclusion, advanced trial, dolutegravir based regimen slightly was better than the efavirenz based regimen, whereas the metabolic syndrome was much more with the dolutegravir TAF based regimen. The osteoporosis and the renal issues were slightly more with the tenofovir based regimen. And so last slide, which is the Nadia trial, which was dolutegravir or darunavir, and you in both the arms, you in dolutegravir or darunavir, you had lamivudine as a fixed NRTI, and the other arm had zidovudine, and either you can use zidovudine or tenofovir either. And what they found was they did not check at the resistance, and even if the NRTIs were resistant, they found that dolutegravir was equivalent to darunavir. So with dolutegravir, lamivudine, or darunavir with lamivudine, irrespective whether it's zidovudine or tenofovir in the arm, they found out in the Nadia trial that it was irrespective of the resistance pattern, darunavir fared equally good as the as the as your dolutegravir brand. So I think this was the Dawning study was the one which compared dolutegravir with lopinavir based regimen. This was meaning comparing dolutegravir with ritonavir. Of course, lopinavir you have to take 5 pills per day, so definitely that issue is going to be there. But again, in this they found out that in Dawning study, dolutegravir based regimen fared much better than the lopinavir ritonavir based regimen. And I think the long-acting cabotegravir, I don't have any experience about this. We'll have to wait, but I think the results seem to be equal. My only worry is just like when you give a rheumatic prophylaxis, Penidura every 3 weekly, the number of people failing to continue that regimen till they are advised at least till 40 years of age or whatever, they drop out. And my worry is that with this injection, whether number of people who would at convenience drop out would be a big question mark. So I think we'll have to wait and watch to see this. And in conclusion, I think in advanced study, we saw that tenofovir, emtricitabine, and I think we discussed in detail about this, that tenofovir, dolutegravir based regimen fared better than efavirenz, and Your TAF with dolutegravir had a metabolic syndrome compared to the tenofovir dolutegravir group. Then two-drug therapy was non-inferior to the three-drug regimen, and even when you switched from three-drug to two-drug, it did not make a change. Your dolutegravir-based regimen or the integrase inhibitor regimen were better compared to efavirenz or atazanavir, ritonavir, or even darunavir, ritonavir, or dopinavir, ritonavir. So I think possibly the way forward, but I wouldn't stamp on this. I think you can choose your regimens, whether it was dolutegravir or bictegravir or efavirenz-based regimen. But yes, your integrase inhibitors fare slightly better. When you use dolutegravir with TAF, it comes with advantages, but the disadvantages, it may cause a metabolic syndrome. I think that's what you have to keep in mind. And that's my last slide. Thanks. And that was the pros and cons about this. Thank you for your kind attention.
Thank you so much, sir, about the talk discussing in detail the various pros and cons of the ARTs. I would request Dr. Falguni Parikh, ma'am, to start her session. Ma'am, please.
Yeah, good evening, everybody. I'll just start my screen share. Are my slides visible?
Yes, ma'am. If you could make it in full screen mode.
Yeah. So good evening, everybody. I think I will be talking about HIV in elderly people. So before I begin, let me just say about what we are going to be, commemorating tomorrow. That is June 5th is a HIV Long-Term Survivors Awareness Day, which celebrates and honors long-term survivor of the epidemic and raises the awareness of their needs, issues, and journeys. Now, there is a syndrome which is known as AIDS survivor syndrome, and this actually describes the spectrum of sustained trauma survivorship resulting from living through AIDS pandemic. And it must have been so traumatic for individuals to have a very serious illness, but not having any cure for it at that point. So today we are indeed, thankful both as doctors and as HIV patients that there are good drugs available. And as we just heard from Dr. Nagvekar's lecture, that we have now at least a good number of tablets from which we can choose from. Otherwise, there used to be pictures of a bucket full of medicines that the AIDS patients had to take at that time. Now, it is estimated that 70% of the older patients with HIV have symptoms of trauma related to that event. So what do you mean by long-term survivors? So long-term survivors can either belong to the pre-HART era, that is before this effective antiretroviral therapy was available, and they are actually the longest term survivors because they refer to these people who have been living with HIV before the modern era of effective HART. And the post-HART long-term survivors are people who have been living with HIV for more than 10 years. That is, who were diagnosed after 1996. That's when the HART became available. These people account for 5% of the new infections. And why are we really talking about long-term survivors? This is because many HIV providers, they lack geriatric training and may not know how to care for aging patients and age-related complications. And as we heard in Dr. Kakar's lecture, it is so important to have a holistic view of the HIV patient because HIV teaches you everything about medicine, pharmacology, microbiology, and pathology. So care needs to be adapted to meet the needs of patients who are elderly. So the scope of this lecture would be recognizing HIV in elderly patients, assessment of older patients, and special issues which we face whilst managing old patients with HIV, including their age-related complications and syndromes. So fortunately, effective ART has enabled people to live with HIV, but the population with HIV is also aging. So older people with HIV are able to have long, productive lives. Because of HIV, they are likely to experience advanced aging. They can have multiple comorbidities. So because they are living more, they have things like diabetes, blood pressure, what the usual people have. Polypharmacy is a problem in geriatric population, as we know, because they are on multiple medications. And when when patients are on ART, it is our duty to ensure that there are no drug-drug interactions. Frailty and other age-related syndromes, which are touched upon by Dr. Kakar, is important because frailty leads to increased morbidity and mortality in these patients. And of course, having a disease as serious as HIV can have mental health issues like depression, which needs to be delved into. See, estimated HIV infections in the US, this is the 2019 data. You can see that the majority of patients are between 25 to 35 years age group, but there are patients between 45 to 55 and higher. And in India, according to a mathematical model in a public health journal, it is said that we will have 37% of our patients, HIV patients, which will be more than 50 years by 2025. So what is the challenge of diagnosis of HIV in older people? So what happens is, according to another statistical criteria, more than half of people living with HIV in the United States are age 50 or older. And many of these people were diagnosed with HIV in their younger years. But all the same, as we saw in the previous chart, thousands of older people get HIV every year. So it is less likely that elder people will get tested, because younger people, they have different lifestyles, so they are more aware about this, so they would get tested for HIV earlier. Older people, usually they might be coping with other diseases and aches and pains of normal aging, and these can mask the signs of HIV/AIDS. So HIV/AIDS has to be kept in the differential diagnosis when we think of certain symptoms or signs. Some older people may feel ashamed or afraid of being tested, so they may not really get tested. And doctors also always do not think to test older people for HIV. Lack of access to very high quality healthcare facilities and services can limit treatment options for our patients with HIV. And by the time an older person is diagnosed, the virus may be in late stages and may likely progress to AIDS. Also, HIV has serious health implications for older people. It can cause economic insecurity. It can create new duties of self-care and instances of social isolation due to stigma. So when a person is growing older with HIV, we must include a geriatric approach that we have for older patients, even in patients with HIV. So this is by the 5 M's. That is the mind. So they should be in a good state of cognition, mobility. So they should be able to do their day-to-day activities and be mobile. They should be up to date with their medications so that their disease is kept under control. Of course, at this age, they will have multiple diseases, so there'll be multi-complexity. But as physicians, we need to understand that, we have to see that each disease is looked into and looked after, and matters most to me. So ultimately, what really matters is what the patient wants out of his treatment. So that is, of course, the most important thing that needs to be looked into when we look after an elderly HIV patient. So what are the components of comprehensive geriatric care assessment? And this we need to know because, in a busy practice, many times we tend to forget, and sometimes elderly people take some time to give their history. So instead of becoming impatient, if we have this little chart in front of us, we hopefully should not be missing out on some important assessments that we need to make in patients with HIV who are geriatric. So basic activities of daily living, whether they are able to do all that, overall health status, so what is their quality of life, cognition, whether we can pick up early dementia by if they say that they are forgetful or if they forget to take their medications, because this has implications on treatment. Mental health, because as I said, that they suffer from self-isolation sometimes, and they do have underlying depression which needs to be picked up so that they can be given help. Nutrition, muscle mass and bone health are very important, both from treatment point of view and from response to treatment. Social supports, because these patients need to come to the ART clinic or they need to come to our OPDs, etc. So they need that support for somebody to bring them. They usually have multimorbidity, so that needs to be looked into, and each morbidity has to be taken care of. Their medications need to be, because if there are many medications, sometimes the patients get flustered. So we have to be a little patient about explaining those medications to them so that there is no over medication or under medication, or they don't forget taking their medications. Frailty, as already alluded to by Dr. Kakar, is a very, very important thing. And this is a big thing in all diseases now, because it increases the morbidity, mortality, improvement from operations, etc. And of course, depending on what an individual patient faces, advanced directives and mobility have to be assessed. So when we assess a geriatric patient in a busy OPD, we have to determine what is practical. We have to devote our resources to screening and assessment of the domain which is most important. And many times, instead of just getting irritated about it, we should just focus on even one single assessment if that is possible, maybe like muscle mass or bone health, etc., because getting started is more important. They have to have adequate symptom control. So patients may need pain management, patient may need palliative care, they may even need psychosocial and spiritual support. So this needs to be looked into. When we manage ART on a patient who is old, we need to ensure, Dr. Vasant has told in details about individual ARTs, but I'll just go over broad principles. So we need to see the comorbid conditions which require polypharmacy. So of course, we need to look into drug-drug interactions, and we have drug interaction checkers and charts like Liverpool chart, etc., which we can take help of if there are some unusual medications. Then physiologic changes do occur with aging, like the creatinine clearance diminishing, etc. Drug metabolism gets affected because of reduced GI transit time, kidney and liver dysfunction. So these pharmacokinetic and pharmacodynamic properties have to be kept in mind when we are prescribing medications. Special attention has to be made to medication side effects. Sometimes we may need to switch therapy. So if patient is on multiple drugs, we can combine drugs, or even as far as ART is concerned, if a patient is well controlled, there are trials which say that you can only use 2 drugs. So it can be considered in patients who develop renal or bone dysfunction. In NRTIs, the renal function needs to be assessed at regular intervals. And as we know, TDF and boosted PI can give rise to frailty and bone fractures. So if that does occur, we possibly have to look out for alternative options. So whenever we look into a prescription of an old HIV patient, it is important that we look into all these aspects. And it is very difficult, believe me, but if we go one by one, I'm sure we'll be able to pick up drug interactions or anything that should not be given with the drug. So prescribing in old people with HIV, we should prefer single drug regimens so that, they don't really forget their pills, or 2 drug regimens if the need be, like I alluded, if there is renal or bone involvement. ART regimens may need tailoring as per the patient needs. And as we last heard, there are long-acting injectable agents which may become the standard of care in the future, because then they don't really have to remember to take pills on a daily basis. And always when the patient comes to us for follow-up, we have to have a regular review for reducing their pill burdens, dosing frequency, increasing their tolerability, and decreasing drug-drug interactions. This is more simple to say than to put into action, but we just have to ensure that they are not on multiple vitamins and multiple medications which are not really actually required, because sometimes they end up taking vitamins and forgetting the ART pills. So it is important that we review their prescriptions at regular intervals. Now about women with HIV, it is special because older women with HIV need more care because they are more vulnerable to cognitive dysfunction, cardiovascular disease, and bone diseases as compared to HIV negative counterparts. Women with HIV, they deserve a special attention because they report worse health-related quality of life and greater HIV-related morbidity than men. Menopause may be earlier, and these may predispose them to earlier onset of diseases whose risk increases after menopause, like fractures, diabetes, etc. Fatigue, joint pains, and mood disorders can also occur in these women post-menopause. They can have accelerated aging, and there is increased morbidity secondary to changes in postmenopausal cardiovascular, microvascular, skeletal, and immune systems. So that is why if you have an older woman who's coming to you, we have to have special to be looking into, especially in all these aspects, so that we pick up things early. What about cardiovascular disease in elderly patients? So in HIV, there is a higher risk of cardiovascular disease because of chronic low-grade inflammation and persistent immune activation. And there is increased hypercoagulability, dyslipidemia, microvascular dysfunction, and of course, there are some changes related to ART regimen like abacavir, protease inhibitors, etc., which make a person prone to cardiovascular disease. Again, as I said earlier, women are at elevated risk of chronic heart failure and ischemic heart disease. So when we are looking at evaluating a patient for cardiovascular disease, functional rather than an anatomic imaging modality should be more sensitive due to presence of microvascular diseases. When we talk about cognitive changes, HIV-associated neurocognitive disorders are still prevalent despite of the patient being virologically suppressed. There can be vascular dementia due to microvascular changes, cardiovascular disease, and metabolic syndrome because of the drugs that we just heard, that weight gain, etc. Synergistic side effects of opioid and anticholinergics if they are given for different purposes. Women, again, are at higher risk of ischemic stroke, and to encourage physical activity may be protective in all our HIV patients. Bone health, accelerated bone loss and increased fracture risk is there in women with onset of menopause. The BMD decreases twice as much in an HIV-infected women as compared to men. However, the osteoporosis risk is multifactorial in an HIV patient, and we can use the help of FRAX score and DEXA scan to evaluate. So maybe once a year, if it is possible, DEXA scan can be done to see what is happening, and calcium and vitamin D supplements can be encouraged. And we know that with tenofovir, it is always good to give some vitamin D supplements. Cancers are an important thing, and it always has to be thought of in patients with HIV. So if you're monitoring a HIV patient and suddenly his CD4 count tends to fall despite of the viral load being normal, maybe it can be an indication that patient is developing some problem. Any unusual weight loss or a decreased appetite in a person who is virologically suppressed can also make you think. And of course, when we are talking about cancers, we have to ensure that our HIV positive patients refrain from alcohol and smoking, which can make them more prone to developing different type of cancers. So it is better that they are regularly screened for cancers, not only those known to be AIDS related like cervical cancer, but also not associated with HIV like breast and lung cancer. So regular mammographies, x-rays, etc. should be encouraged. And of course, we test always for hepatitis B and C. So even those, virus-related cancers can be picked up. When we talk about young long-term survivors of HIV, I just thought I'll add a little on this subset also, because these are, people who have acquired HIV at birth or perinatally, and it is found that younger long-term survivors were more likely to have the HIV treatment to be unsuccessful than adults, because they have been exposed to HIV treatment in the womb, and that increases their chance of HIV drug resistance. And their treatment histories tend to be just as complex as those described for the older people, and they are complicated by fewer medication options for children due to fixed doses and the need for dose adjustment for weight. And this can be a real problem, especially in this age group. And young people find it more challenging than adults to take the HIV drugs consistently enough for the drugs to be effective. So it is very important that for all ages, the people should have trusting relationships with their healthcare providers so that they can work together to improve long-term health outcomes and quality of life. So in conclusion, HIV in older age needs to be highlighted and addressed. The problem is not going away as more people are aging, and with this infection, we must be prepared. Prevention and management must be carefully addressed to ensure older men and women with HIV are not sidelined. Optimal care, that is 5 M's, should be remembered. We should try and do a comprehensive geriatric assessment when we have an elderly patient with us. Special attention to women's health due to increased susceptibility to comorbidities like cognitive impairment and bone disease must be kept in mind. And Because we know that there is accelerated aging in these patients, risk mitigation and screening should begin at a younger age. I also need to emphasize the need for vaccination and immunization in all our HIV patients. With this, I end my talk and I'll be happy to take any questions with my co-persons. Thank you very much.
Thank you so much, ma'am, for such an interesting lecture on this topic of how to manage HIV in the aging population. Now, I would request the audience, if they have any questions, they can come up with in the chat box as well. Audience, any questions?
Dr. Shreya,
Yes, ma'am.
Can you hear me?
Yes. Ma'am, there is a query from Dr. Aniket regarding treatment for dolutegravir-induced hyperglycemia.
So, the metformin may have an issue. So, either you can change to raltegravir, or you have to decide what medications do you really want to take in patients with diabetes. Now we have a lot of options available for diabetes, so the safer medications can be used.
Okay. Any other question from the audience?
I think there are some questions in the chat box.
Yes, ma'am. I think those have been answered by Dr. Vasant. So. Ma'am, there is one more question, sir, as well. Can we initiate 2-drug regimen in older patients de novo?
Yeah, I think we have seen that, both the Gemini 1, Gemini 2 and the Tango studies that, 2-drug regimen has been equivalent to your 3-drug regimen. And yes, you can start with the, if required. I have not used in my clinical practice, but I think that's the way forward possibly. Because in the US and everywhere, they have come up with 2-drug regimen. So even in naive patients or even patients who have been on prior treatment. So yes, you can go ahead instead of 3-drug. You can go ahead to dolutegravir, monitoring closely the CD4 environment.
Okay. There's a question from Dr. Kirti. What is the role of CD4 count nowadays? And has it any role in HIV PCR?
Sorry, what was the question?
What is the role of CD4 count nowadays and any role in HIV PCR?
So I think I've answered that in the chat box, saying that your drugs do not work on the CD4, it works on the virus. And so it suppresses the viral load. So I think it's very important to monitor your viral load, which our Indian guidelines and NACO was, they were basically more onto the CD4. But I think of late, we have seen that even the government and municipal hospitals are doing the viral load. It's very clear that your medications work on the virus and your viral load suppression is the key to your success of the treatment. CD4 is variable and CD4 can be variable according to your WBC count. It could be because of some viral infections and so many other cofactors which are there. So CD4 is equally important, but I would say viral load is more important when you looking at your clinical, whether your medication is working or not, whether there's a virological failure occurring or not. The CD4 count will not tell you that. So whether there are virological blips occurring, so all that will be more on the virus. So I give more weightage to the suppression of the viral load. Even if you do it once in a year, also it is good enough. If your patient is adherent with your regimen, once a year of doing a CD4 viral load is good enough. So I follow my patients once in a year if they are being adherent to the regimen and if I'm confident about them. So that's the way to go.
As I said in my lecture, if the CD4, I mean, initially in the ART clinics, the CD4 count used to be done. So in a well-controlled patient, if the CD4 count drops despite of the viral load being normal, you do look out for, development of malignancy or development of some other infection.
And there is one more question. What is the treatment for stavudine-induced lipodystrophy?
So we don't use stavudine any longer.
And there's no reversal, I think.
There's no reversal. At the most, you can try some Botox or, the fillers, etc.
Thank you, ma'am. Thank you, sir. One more question. Is it from Dr. Murthy? Is it better to switch to 2-drug regimen instead of 3-drug regimen to prevent bone and kidney complications?
So I think we have discussed the pros and cons about dolutegravir TAF causing a benefit with bone and kidney, but causes a metabolic syndrome in around 10% of females and around 7% of men, not in each and every person. With dolutegravir tenofovir, we have seen that both dolutegravir and tenofovir can cause some renal issues as well as tenofovir causing some osteoporosis. I would suggest that we start with 3-drug regimen, monitor the patient, his creatinine, and if maybe once in 2 years or 3 years, if it's a female DEXA scan, and if there is a concern, then possibly you can switch over to 2-drug regimen. So I would, as of now, in my clinical practice, I would still go with 3-drug regimen, and maybe if any of these bone or renal issues or metabolic syndrome comes, then possibly I would switch to 2-drug regimen.
I absolutely agree with Dr. Vasant, but I just had a thing to say that, we shouldn't carry that message that it's okay to use the 2-drug regimen. So we have to start with the 3-drug regimen, and only when the patient is virologically suppressed and there is no associated hepatitis B should we be, dropping the tenofovir, because otherwise if we drop the tenofovir and continue the other 2 medications, then the hepatitis B can resurface again. So these are 2 things that we have to keep in mind when we are talking about dropping the tenofovir for whatever purpose.
Ma'am, one more question is there, how to avoid cardiovascular risk due to dolutegravir?
So, unfortunately, the weight gain is, it is there with dolutegravir. So when the patient is made to understand that it is just generally what we do with other patients, that is maintain, a healthy lifestyle, try to exercise a little bit and monitor the parameters more regularly so that the patient doesn't get like a 10 kg weight loss, 10 kg weight gain suddenly, because weight gain is known. So, only thing is that the other factors can be taken care of. And, if there is dyslipidemia, you can give statins, etc. So these are the things that you need to look into. And checking for sugars and all, the other comorbidities.
Dr. Aniket wants to know what must be the frequency of doing DEXA bone scan for the patients on TDF?
I would do it once a year.
So your views?
Yeah, I think maybe a year or 2 yearly, but yes, that requires to be monitored, especially when the patient is on a tenofovir TDF-based regimen. And especially more in females than in males.
Thank you, sir. Thank you, ma'am, for answering these questions. Mr. Balaji?
Yeah, thank you, Dr. Shreya. This is Balaji. Very happy to participate in this webinar this evening. And happy that we have a very distinguished panel of speakers who bring a plethora of experience. And that is what I can see when they have presented. And thank you very much, Dr. Vasant and Dr. Falguni and Dr. Atul. I made a few observations which I thought I should bring it to your attention. Dr. Vasant, the HLA-B testing for abacavir, is it being done in children? Do you think it is? I don't think it is done in children, if I'm not mistaken.
I'm not sure about that, but because I'm not, I do practice pediatric HIV, but I've not been, as I said, Abacavir is not a first line treatment in India at all. It is always TDF or TAB based regimen, or it could be dolutegravir or efavirenz based regimen. So that has not been done, but I do not know about HLA-B57 being
And
done.
children,
But I think the risk should be the same, no? Whether it's adult or children.
The other observation was that basically the regimen switch from efavirenz, basically it started off sometime in 2017-18 when the WHO brought in guidelines that any country with which is showing a drug resistance of more than 10% will have to look out for an alternate regimen, and that's what sort of triggered when countries started reporting efavirenz drug resistance. And added to that, the dolutegravir regimens which were introduced sometime in 2018, 2019 guidelines with the WHO. Today, more than 150 countries worldwide have switched to a dolutegravir-based regimen, and then they are not talking about going back to efavirenz for reasons best known to all clinicians. So the question of whether it is going to be 400 or 600 is in fact becoming very sort of distant nowadays, as I can sort of see. So in the evolution of the integrase inhibitors, although bictegravir came earlier to dolutegravir, the dolutegravir was able to address the deficiencies of bictegravir. For example, the use of bictegravir in patients who are co-infected with tuberculosis is still not there. And similarly, the use of bictegravir in pregnancy and also in children is the reports are still not available. So since dolutegravir was able to address all these aspects, so it has become a cornerstone in terms of treatment. And now in India itself, we have 5 different formulations of containing dolutegravir. Added to that, the NACO in its treatment guidelines have stopped procuring efavirenz-based regimens. If you look at the triple drug regimen, it is the TLD, and it is in line with the WHO guidelines, and it is also in line with what is happening in more than 150 countries. So in a way, the dolutegravir has sort of addressed the deficiencies of what the bictegravir happened, although bictegravir came much earlier than dolutegravir. So thank you very much for this enlightening talk and your time, precious time this evening for enlightening us on all these aspects, Dr. Falguni and Dr. Vasant. And we are very grateful to you for your time and presence and the knowledge that you have been able to share with all of us.
Can I make a comment, Dr. Balaji?
Yes, doctor, please.
Yeah. So I think with this more than 10% resistance with efavirenz or NNRT based regimen, I think as you said, many of the countries have switched more than 152 dolutegravir based regimen. But having said that, I would still urge people or all the doctors to those who have been on efavirenz based regimen or on nevirapine based regimen. If your patient is not encountering any adverse events, and if they're doing extremely well virologically and immunologically, I would urge to continue, and that's what I'm doing in my clinical practice. I'm not switching them from efavirenz based regimen to dolutegravir based regimen. There are 2 reasons. One is they're doing well, they don't have any adverse effects. Second is when you switch to dolutegravir based regimen, you're dropping the efavirenz based regimen, and so some reason the patient is not able to tolerate dolutegravir for whatever reason. Switching back to efavirenz may be a concern because once you drop efavirenz, the resistance to NNRT is very fast. So I would urge, if the patients are doing well and they're not encountering any adverse effects, please continue the same regimen. At the most, maybe efavirenz 600 to 400 is an option, if at all, if you want.
Sure.
Yeah, I agree,
Yeah.
Dr. Vasant.
Very true. So thank you, doctors, and for your time and your presence, and have a very good evening, and enjoy the rest of the day, and a happy weekend to all of you.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you, audience.